Our lecture is about neonatal intestinal obstruction. In this lecture, we are going to discuss the following points. First, we have to define what is the meaning of neonatal intestinal obstruction. The second, what is the incidence of this condition. The third, some terms that are commonly used in this condition. Then, what are the causes of neonatal intestinal obstruction, the pathophysiology of this condition. After that, we will explain what about the clinical picture, diagnosis, treatment, and lastly, we will discuss some different conditions, some different types of neonatal intestinal obstruction. First, what is the meaning of neonatal intestinal obstruction? Intestinal obstruction means failure of propulsive movement of the intestine that pushes the intestinal contents distally from the stomach down to the rectum and the anal canal. Neonate is the newborn baby during the first 28 days of life. So, neonatal intestinal obstruction can be defined as failure of propulsion of the intestinal contents distally in a newborn baby during the first 4 weeks of his life. This condition may be due to either mechanical or functional causes. Neonatal intestinal obstruction is the unique condition that is explained away from the big topic of intestinal obstruction because most of the conditions in neonatal intestinal obstruction are of congenital origin, while in those of adult intestinal obstruction, most of the conditions are acquired conditions. So, neonatal intestinal obstruction most commonly is due to congenital factor. So, they usually present early in the life. What is the incidence of this condition? The incidence of this condition gives us an idea about how frequent you will meet this condition, and the second, the incidence also gives us a clue about we have to prepare ourselves for this condition if it is a frequent condition. But if it is infrequent condition, so we are not going to prepare ourselves for a special condition, meaning that the intestinal obstruction, neonatal intestinal obstruction, is the most common surgical emergency in the newborn. The incidence is about 1 in every 500 to 1000 live birth. 50% of these neonates will have either intestinal atresia or stenosis. As we will discuss later, there are different causes for neonatal intestinal obstruction, like the intestinal atresia, intestinal stenosis, malrotation, meconium ileus, Hirschsprung, etc. 50% of the condition of this condition is due to intestinal atresia. During this lecture, we are going to meet some terms that may be new for us, like atresia, web, malrotation, and meconium ileus. So before going into enumerating the cause of neonatal intestinal obstruction, we have to explain some of these terms. First, we will explain what is the meaning of atresia. Atresia and web are the same condition but different presentation. Atresia means atretic segment of the intestine, means that there is a loss of the continuity of the intestine due to congenital condition. This congenital condition is mostly due to intrauterine vascular accident that results in ischemia of a part of the intestine, and because this condition occurs in utero, so we call it clean ischemia or non-septic ischemia. So the result of this ischemia is not peritonitis, but the result of this is loss of a segment of the intestine. So atresia means loss of continuity of the intestine or interruption of the continuity of the intestine. This atresia is of different types according to the level or according to this atretic segment, and is it associated with a defect in the mesentery or not. What about the web? The web is a type of atresia, but in which we call it type 1 atresia, where there is a web or a membrane or a diaphragm that is obstructing the lumen of the intestine. So the web is a membrane or a diaphragm that occludes the lumen of the intestine. So there is no loss of continuity, but there is intraluminal obstruction. This web may be complete or incomplete. The incomplete web means that there is a hole in this web, so it permits the passage of some intestinal contents, so it produces a picture of partial intestinal obstruction that presents usually later than the complete atretic type. Okay, so this is atresia, and the atresia has different types as we will explain later. Okay, the second term is malrotation. Mal means abnormal. Rotation is the rotation of the intestine. As we know, during development of the midgut develops from the duodenal limb and the cecocolic limb. Okay, during its development, the duodenal limb rotates into 270 degrees around the cecocolic limb. So the orientation of the intestine will be, as we know, the duodenum will be C in shape. The duodenojejunal junction will be to the left of the vertebral column. The small intestine will be in the middle of the abdomen, and the cecum will be in the right iliac fossa, and the colon will be like an inverted U, taking the periphery of the abdomen. This is the normal orientation that results from normal rotation of the intestine. Due to abnormal rotation of the intestine, there will be loss of the C shape of the duodenum, and the cecum will be in the middle of the abdomen, and there are bands that cross from the cecum to the lateral abdominal wall, crossing the duodenum and producing the picture of duodenal obstruction. So malrotation means intestinal obstruction due to abnormality in the normal rotation and orientation of the intestine. Okay, the last term is meconium ileus. What is the meconium? Meconium is the normal stool passed by the baby during the first 24 hours of his life. Okay, the normal meconium is dark green in color and it is not viscid, so it is passed easily by the baby during the first 24 hours. Sometimes in some condition like the meconium ileus, this meconium becomes very thick, viscid and tenacious due to loss of pancreatic enzymes. In a condition called cystic fibrosis, loss of pancreatic enzymes results in failure of degradation of the protein content in the meconium. So the high protein content in the meconium results in a very thick, viscid, tenacious meconium that failed to pass down its stream, so it occludes the terminal ileum. So meconium ileus is some sort of intestinal obstruction due to very thick, viscid and tenacious meconium that adheres to the wall of the terminal ileum, producing the picture of distal intestinal obstruction. Okay, this is the picture of meconium ileus. As we see here, the meconium is very thick and viscid, and it looks like pellets in the terminal ileum. Why it occludes the terminal ileum? Because the terminal ileum is the narrowest part of the small intestine. So the meconium becomes adherent to the wall of the terminal ileum and produce the picture of intestinal obstruction. So we take some terms that will benefit us in the following explanation. After that, we will enumerate what are the causes of neonatal intestinal obstruction. There are common causes of neonatal intestinal obstruction, and there are many uncommon causes. We will stress on the common causes. The common causes of neonatal intestinal obstruction first is intestinal malrotation, and as we said, intestinal malrotation means intestinal obstruction due to abnormal rotation and orientation of the intestine that results in obstruction of the duodenum. The second is atresia, and as we said, what is the meaning of atresia? Atresia means loss of continuity of the intestine due to intrauterine vascular accident. This atresia may affect the duodenum, may affect the jejunum, may affect the ileum, or may affect the colon. So we have duodenal atresia, duodenal stenosis. Duodenal stenosis means narrowing of the lumen but not complete occlusion, and the annular pancreas. Okay, jejunal atresia or stenosis, ileal atresia or stenosis. Meconium ileus, as we said, meconium ileus means distal ileal obstruction by the very thick viscid meconium that becomes adherent to the wall of the terminal ileum. Okay, meconium plaque syndrome. Meconium plaque syndrome is something like the meconium ileus that is very thick piece of meconium, not the whole meconium, very thick piece of meconium that includes the colon, not the ileum, and after passage of this plaque, the baby will be relieved. Okay, Hirschsprung disease. Hirschsprung disease is a common cause of neonatal intestinal obstruction, what we call functional obstruction, and we will explain that later on. The last cause is drug-induced ileus. Drug-induced ileus, the ileus produced in the baby means failure of peristaltic movement of the intestine without mechanical obstruction. What is the source of this ileus? The source of this ileus, sometimes some drugs may be given to the mother before clamping of the umbilical cord. So these drugs will pass from the mother to the baby through the umbilical cord and produce its effect in the baby. The most common of this is the opioid narcotics. Sometimes during labor, the mother may be given opioid narcotics as an analgesic. If these narcotics were given to the mother before clamping of the cord, these narcotics will pass into the baby and produce ileus, and the baby will be presented by the picture of paralytic ileus. These are the common cause of neonatal intestinal obstruction. We can classify neonatal intestinal obstruction into proximal obstruction and the distal obstruction. Proximal obstruction means obstruction of the proximal part of the intestine, including the stomach, duodenum, and the jejunum. So the proximal obstruction includes obstruction at the level of the stomach, duodenum, or the jejunum. Distal obstruction means obstruction including the distal part of the GIT, that is the ileum, the colon, the rectum, and the inner canal. What is the value of differentiating obstruction into proximal and distal? The value of this is the different clinical presentation. In proximal obstruction, usually the baby presents early by vomiting and less distension. While in distal obstruction, the baby usually presents late by marked abdominal distension, late vomiting, and constipation. So the difference between, or the differentiation between proximal and distal obstruction will be discussed later on the clinical picture. After that, what is the pathophysiology of neonatal intestinal obstruction, or the pathophysiology of intestinal obstruction as a whole? The pathophysiology of intestinal obstruction is something that is important. You have to you understand very well, because if you understand what is the pathophysiology of neonatal intestinal obstruction, it will be very easy for you to catch up. What is the clinical presentation of this baby? What are the complications of this baby? And how can we diagnose and treat this condition? In neonatal intestinal obstruction, or any obstruction as a whole, we have three zones. First, the first zone is the site of obstruction. The second is the proximal part to the obstruction, or the proximal intestine to the obstruction, and then the distal segment. At the site of obstruction, this is the site where you will find the cause of obstruction. This cause may be atresia, this cause may be the inspissated meconium, this cause may be bands, whatever. So this is the first zone. The first zone is the zone of obstruction, and you will find here the cause of obstruction. Okay, the second zone is the proximal part of the intestine. The part of the intestine proximal to the obstruction will become dilated due to accumulation of fluid and the gas, because there is no distal passage of this contents into the distal intestine. So proximal to the obstruction, there will be accumulation of gas and the fluid. Okay, the accumulation of gas and the fluid will result in dilatation of the intestine. This dilatation of the intestine will be presented clinically as abdominal distension. Okay, the accumulation of the gas and the fluid lead to increase of the hydrostatic pressure of this segment. That is the pressure exerted by the fluid and the gas on the wall of the intestine. The increased hydrostatic pressure will first compress the veins, because the veins are thin-walled and low pressure. So compression of the veins in the proximal dilated segment will result in edema in the wall of the intestine, and will result in transudation of fluid from this dilated lobe into the peritoneal cavity. Okay, if the obstruction continue and the pressure increased more, so this pressure will compress the arteries. Compression of the arteries will result in ischemia, meaning that decreased blood supply to the wall of the intestine, and may result in gangrene of the intestine. The gangrene of the intestine will result in pouring the contents of the intestine into the peritoneal cavity, producing peritonitis. Okay, so ischemia will result in gangrene, and the gangrene will result in perforation of the wall of the intestine. This perforation will result in peritonitis, and the peritonitis can result in shock, septic shock, because of systemic absorption of the toxins from the peritoneum. Okay. Okay, this proximal segment of the intestine, as in a case of intestinal obstruction, pass into three phases. These three phases are hyperperistaltic phase, then antiperistaltic phase, and lastly aperistaltic phase. So, in any obstruction, the proximal dilated intestine pass into these three phases. First, hyperperistaltic phase. During this phase, stretch of the smooth muscles in the wall of the intestine results in overactive muscle. So these muscles increase its peristaltic movement in a trial to get rid of this obstructing lesion. This is can be presented clinically as this hyperperistaltic movement can be presented clinically as abdominal pain and abdominal colic. Okay. Failure of hyperperistaltic movement to get rid of the obstructing lesion will result in the second phase, that is the antiperistaltic phase. In antiperistaltic phase, the movement, the hyperperistalsis will be in the opposite direction, and this will be presented clinically as vomiting. The vomiting in intestinal obstruction is usually bilious vomiting. Okay, the third phase is aperistaltic phase, means that there is failure of the wall of the intestine, or the wall of the intestine, the smooth muscles in the wall of the intestine becomes fatigued, and it will pass into the phase of aperistalsis, that is meant loss of the movement, and this will be transferred clinically into marked abdominal distension and absence of pain. Okay, so the proximal dilated intestine pass into these three phases. Every one of them will be presented clinically into one of the clinical signs of obstruction. Okay, so this is the second segment, that is the proximal dilated segment. The third segment is the distal segment. The distal segment will be empty and collapsed because there is no contents passing from the intestine beyond the obstruction. So the distal segment will be empty and collapsed. Okay, so in the pathophysiology, the loss of fluid and electrolytes from the vomiting, as the result of vomiting, in addition to the fluid that is sequestrated into the lumen of the dilated bowel loops, will result in dehydration. Oliguria means decreased renal blood flow and inadequate peripheral perfusion, because the body produces peripheral vasoconstriction to maintain blood supply to the vital organs. Okay, this prolonged intestinal obstruction can lead to alteration in the intestinal motility, as we said, hyperperistalsis, then antiperistalsis, then aperistalsis. Okay, the accumulation of the fluid and the gas in the dilated intestine will result in bacterial overgrowth in this stagnant fluid. The marked abdominal distension can splint the diaphragm, meaning that it will impair the movement of the diaphragm, and so this baby may, after some time with marked abdominal distension, may complain of dyspnea and respiratory problems. Due to loss of the plasma volume, there will be alteration in the blood flow that result in bowel ischemia, necrosis, and it will result in peritonitis and toxemia. Okay, after that, what is the clinical presentation of neonatal intestinal obstruction? Neonatal intestinal obstruction, as an intestinal obstruction, have 5 clinical manifestations or 5 clinical findings that usually will find in most cases. The first is maternal polyhydramnios. The second is bilious vomiting. The third is excessive gastric output. The fourth is abdominal distension. And the fifth is failure to pass meconium. First, what is the maternal polyhydramnios? Maternal polyhydramnios means excessive accumulation of the amniotic fluid in the mother. What is the cause of this maternal polyhydramnios? This amniotic fluid is produced by the chorionic villi, and it is swallowed by the baby, passing through the oral cavity, esophagus, stomach, duodenum, and it becomes absorbed in the upper small intestine, when it is absorbed in the upper small intestine, it will pass into the circulation of the baby and it will be excreted by the kidney as urine. Then the baby swallow this amniotic fluid again, and so on. So if there is obstruction of the proximal intestine, meaning that obstruction at the level of the esophagus, stomach, duodenum, or the proximal jejunum, so there will be interruption of the normal circle of the amniotic fluid. So the chronic villi will produce amniotic fluid, and this fluid will not take its cycle, so there will be excessive accumulation of the amniotic fluid. So a maternal polyhydramnios is an antenatal sign, that is, there is proximal intestinal obstruction. In distal obstruction, there will be no maternal polyhydramnios, because suppose that the obstruction is at the level of the ileum. So this fluid will be swallowed by the baby and passed down from the esophagus, stomach, and it will be absorbed in the small intestine. So there will be no problem of polyhydramnios. Okay. The second is bilious vomiting. As we said, the cause of vomiting is obstruction, accumulation of the intestinal secretion, and due to failure of hyperperistaltic phase. The antiperistaltic phase will get rid of the intestinal contents in the opposite direction. So bilious vomiting is also one of the cardinal manifestation of intestinal obstruction. The bilious vomiting will be presented early if the obstruction is proximal, and will be presented late if the obstruction is distal. Excessive gastric output, meaning that in bilious vomiting the obstruction should be beyond the level of the ampulla of water, while if the obstruction is at the level of the stomach, the first part of the duodenum, or the second part of the duodenum above the level of the ampulla of water, so this baby who will vomit, he will vomit just only the gastric juice or gastric fluid, and he will not vomit bilious vomiting. So excessive gastric output is a sign of neonatal intestinal obstruction, and the level of obstruction is above the ampulla of water. Abdominal distension, as we said, due to accumulation of fluid and gases in the proximal intestine, proximal to the obstruction, the loops will be dilated. So these dilated loops will be transferred clinically into abdominal distension. In proximal intestinal obstruction, the distension will not be marked. Suppose that there is duodenal obstruction. So the dilated part will be only the stomach and the part of the duodenum. So the distension will not be so marked. While in distal obstruction, if there is obstruction at the level of the colon, so the dilated intestine will be the part of the colon proximal to the obstruction, the ileum, the jejunum, and the duodenum. So the obstruction will be marked. So in contrary to the vomiting, as we said, in the bilious vomiting becomes early in proximal obstruction and late in distal obstruction. The abdominal distension is not marked in proximal obstruction, but it is very marked in distal obstruction. Failure to pass meconium. As we said, meconium is the first stool passed by the baby. This stool should be passed within the first 24 hours. Failure of the baby to pass the meconium within the first 24 hours indicates there is a pathologic condition. So, in neonatal intestinal obstruction, usually the baby, not always, usually the baby failed to pass the meconium within the first 24 hours. These are the cardinal manifestations. These are the 5 fixed or 4 cardinal manifestation of neonatal intestinal obstruction: maternal polyhydramnios, bilious vomiting, excessive gastric aspirate or excessive gastric output, abdominal distension, and the failure to pass meconium. Okay, as we said, we classify intestinal obstruction into either proximal obstruction or distal obstruction. In proximal obstruction, meaning that obstruction of the proximal part of the intestine, meaning that the obstruction is at the level of the duodenum or the upper jejunum. Distal obstruction means obstruction is at the level of the ileum, colon, or the rectum or anal canal. In proximal obstruction, the vomiting will be early and the distension will be less. Okay, while in distal obstruction, the vomiting will be late and the abdominal distension will be more marked. Okay, this is very important because when the baby is presented clinically, we will take this into consideration, because when a baby is presented in the first day of life by bilious vomiting and epigastric distension, or mild abdominal distension. In that case, we will think about a proximal obstruction, meaning that the obstruction is at the level of the duodenum or the upper jejunum. While a baby is presented, if a baby presented after 3 or 4 days of life by marked abdominal distension and vomiting for one or 2 days, this means that the obstruction is at the level of the distal intestine, maybe the distal ileum, colon, rectum, or the anal canal. Sometimes the baby may be presented by the clinical picture, and sometimes this picture may be complicated, as we said in the pathophysiology. Progressive accumulation of fluid and gas and prolonged obstruction may result in complication. This complication include dehydration, and the dehydration results from first the vomiting that occurs either bilious or non-bilious. The second, the transudation of fluid from the intestine into the peritoneal cavity. This leads to decrease in the intravascular volume and will result in dehydration. The second, electrolyte disturbance. When the baby vomits, he vomits not only the fluid but also vomits the succus entericus, this is the intestinal secretion, and also vomited the gastric juice, and both of them contains electrolyte like sodium and potassium and chloride. So in vomiting, the vomiting will result in dehydration and also will result in electrolyte disturbances like the hypokalemia and the hyponatremia. Okay. Also, the baby may be presented by shock. The shock may be due to hypovolemic shock as a result of dehydration, and there may be septic shock due to peritonitis. Okay, volvulus and bowel strangulation. This is also a complication of intestinal obstruction if there is a compromise of the blood supply of the intestine. The bowel strangulation will result in bowel perforation, and the bowel perforation will result in peritonitis. The peritonitis will result in toxic absorption and septicemia. So these are the complications of neonatal intestinal obstruction: dehydration, electrolyte disturbances, shock, either septic shock or hypovolemic shock, volvulus and bowel strangulation, bowel perforation and peritonitis, toxic absorption, and septicemia. This is the clinical picture of neonatal intestinal obstruction and its complication. And also always remember that the baby may be presented by simple obstruction. This is the clinical picture as we explained, and sometimes may be presented by the complicated obstruction, meaning that in addition to the clinical picture of obstruction, the baby may be presented by one or more of these complications. Okay, if the baby is presented to us by this clinical picture of intestinal obstruction, what we are going to do for this baby? First, we will diagnose this baby clinically, and during clinical diagnosis you have to put in your mind that, okay, early vomiting and less abdominal distension indicates proximal obstruction, and late vomiting and marked abdominal distension indicates distal obstruction. So the clinical diagnosis is very important in suspecting the level of obstruction. Okay, after we suspect the level of obstruction, we may do some radiology. The radiologic diagnosis that can help us in diagnosing the level or the type of obstruction, we can do a plain X-ray abdomen in the supine and the erect position, or sometimes we cannot do the erect position in the neonates, so we will replace the erect position by what we call cross-lateral position. So we do either supine and erect or supine and cross-lateral position. Sometimes the plain X-ray cannot define the cause of obstruction, and we may need to do a contrast imaging, meaning that we will give a contrast either from above in gastrographene meal and follow through, or from below in gastrographene enema. Okay, in addition to laboratory investigation like CPC, electrolytes, and arterial blood gases, EBG, and we have to investigate for Vactrel. What is the Vactrel? Any baby presented by a picture of congenital anomaly like neonatal intestinal obstruction, always suspect there may be associated anomalies. So when a baby is presented by a congenital anomaly, always suspect that there are other congenital anomalies, and you have to search for. The common anomalies are gathered together in the term Vactrel. Vactrel means V for vertebral anomalies, A for anorectal anomalies like imperforate anus, C for cardiac anomalies, TE for tracheoesophageal, R for renal anomalies, and L for limb anomalies. Again, V for vertebral anomalies, A for anorectal anomalies, C for cardiac anomalies, TE for tracheoesophageal anomalies, R for renal anomalies, and L for limb anomalies. First, we will do a plain X-ray. What is the value of the plain X-ray? The value of the plain X-ray is that when the baby is in during antenatal or during intrauterine life, the abdomen is gasless. There is no gases in the intestine, so you will find the abdomen like this one. This is a gasless abdomen. In the abdomen, you will find no gases. After birth, the baby starts to swallow air, and this air will pass down from the esophagus, the stomach, the duodenum, the jejunum, ileum, and then go to the colon. Okay, during its journey, it passes into every station at certain time, meaning that the air reaches the proximal small intestine, meaning that the stomach, duodenum, and upper jejunum within 30 minutes. Okay, and usually reaches the distal small intestine within 3 to 4 hours, and usually go into the colon to reach the rectum by 6 to 8 hours. So in the newborn baby, we can use this air as a contrast, meaning that the abdomen is gasless and the air will go into the abdomen. So suppose that the baby has a duodenal obstruction. So the air will pass from the esophagus into the duodenum, into the stomach, and then the duodenum above the level of obstruction, and there will be no air distal to the level of the duodenum. So you will find the air in the duodenum and the rest of the abdomen is gasless. Okay, suppose that the level of obstruction is in the ileum, so the air will pass down into the stomach, duodenum, jejunum, the ileum proximal to the obstruction. Okay, distal to the obstruction means that the distal ileum, colon, rectum, and the anal canal, there will be air, no problem in that. There will be no air, sorry for that. Okay, so we can use the air as a contrast in the newborn babies. Normally you will find pockets of gas scattered in several areas of the abdomen, but there should be no air fluid levels in the erect film, and there should be no dilated loops. Okay. This is the picture of a plain X-ray abdomen that is gasless. If you look at the abdomen, you will find that there is no gases in the abdomen at all. So this is the normal X-ray abdomen in a baby before birth. Okay, or if the plain X-ray is done for the baby immediately after birth, you will find it like this one. There is no gases in the abdomen at all. After that, the air starts to distribute in the abdomen, so you will find that there is a pockets of air distributed in the abdomen. Okay, but if you look at it, there is no dilated loops and there are no air fluid levels. Okay, in neonatal intestinal obstruction, you will find that there are dilated loops. The loops will be dilated, and there will be air fluid levels. The air fluid levels is due to the presence of air and the fluid in the loop. So in the erect position, the fluid will take its level and the air will be above it. So you will find dilated loops and multiple air fluid levels. But in meconium ileus, as we will discuss later, you will not find air fluid levels, because as we said, the cause of air fluid level is the presence of fluid and air, while in meconium ileus, the viscid, thick, tenacious meconium will not be mixed with air, so there will be no air fluid levels. Okay, the plain X-ray abdomen and the neonatal intestinal obstruction, if there is complete obstruction, the air pattern usually stops at the level of obstruction, and the rest of the abdomen will be gasless. As we said, in duodenal obstruction, you will find the air in the stomach and the duodenum, and the rest of the abdomen will be gasless. While in partial obstruction, a small amount of air will pass beyond the level of obstruction, so there will be gases distal, but this gas will be few. So we call it, there is a paucity of gas bowel in the distal bowel and can be identified as abnormal, meaning that this air is not normal. Okay, this picture for a case of duodenal obstruction, if you look at it, you will find there is two gas bubbles. okay, one in the stomach and one in the duodenum. So this is called double bubble sign. Okay, the gas or the air in the stomach, this is one bubble, and the air in the duodenum, this is the second bubble. And if you look at the rest of the abdomen, you will find that there is no gases, so the abdomen is gasless. So this is the picture of the duodenal obstruction. Okay, while in this picture you will find there are multiple dilated loops. Okay, these multiple dilated loops mean that the level of obstruction is distal. Distal obstruction means obstruction at the level of the duodenum or beyond it, like the colon, rectum, or the anal canal. But we cannot define the level exactly because the multiple dilated loops, we cannot define which part of the small intestine is affected. Okay. The abdominal film should always be inspected for peritoneal or scrotal calcification. Peritoneal or scrotal calcification indicates that their intrauterine perforation occurs and the meconium induced chemical peritonitis of the intestine, and one of the dystrophic changes that occur with inflammation is the calcification. Okay, so when we look for an X-ray of the abdomen, we will look for calcification that may be present in the abdomen. The presence of calcification indicates meconium peritonitis. Okay, specific radiographic abnormalities of the lesion. Some lesion may have specific radiographic abnormalities. For example, the meconium ileus. In meconium ileus, you will find something called ground glass appearance, and you will find that there is no air fluid level. You will find multiple dilated loops because meconium ileus is an obstruction of the distal ileum. So there will be multiple loops that are dilated, and you will find multiple dilated loops, but there is no air fluid levels at all. Sometimes we cannot define the level of obstruction or the cause of obstruction from the plain X-ray, and in that condition we have to do a contrast study. A contrast study means we have to give a material that can outline the small intestine. If we give it from below, from the rectum, it is called gastrographine enema, and if it is given from above, it is called upper GIT series or gastrographine swallow and meal and follow through. Gastrographine swallow for the esophagus, meal for the stomach, and follow through for the whole of the intestine. Okay, barium or gastrographine contrast enema is useful in cases of distal small bowel obstruction like ileal atresia, meconium ileus, Hirschsprung disease, or meconium plug syndrome. Okay, and remember that gastrographine only, not barium. Gastrographine contrast enema may be therapeutic in cases of meconium ileus. Okay, gastrographine and not barium. Gastrographine contrast enema may be therapeutic for cases of meconium ileus. In the upper GIT series, upper gastrointestinal barium studies or gastrographine studies, this is mainly useful in diagnosis of abnormal bowel rotation that we call intestinal malrotation. So it is only done for cases of partial obstruction that cannot be confirmed by the plain radiographs. Okay, so we diagnose the condition either clinically, so we diagnose this baby with neonatal intestinal obstruction based on the clinical presentation and based on the radiographic diagnosis. Radiographic diagnosis may be plain X-ray, and sometimes we may need to do a contrast study either from above, gastrographine swallow, meal, or follow through, or from below, gastrographine enema. Okay, so this baby is diagnosed as neonatal intestinal obstruction, and we will diagnose the level like duodenal obstruction, malrotation, meconium ileus, Hirschsprung disease, whatever. Okay, what we are going to do for this baby? This baby, before going to the operation, we have to prepare this baby, because this baby when comes to us, he may have abdominal distension. This abdominal distension can impair the diaphragmatic movement and produce dyspnea. This baby may be dehydrated. This baby may be shocked. Okay, so we have to prepare this baby before the operation. The preoperative management includes nasogastric suction, fluid and electrolyte resuscitation, in addition to antibiotic, etc. First, in case of neonatal intestinal obstruction, you have to put a nasogastric tube. Okay, we pass a nasogastric tube from one of the nostrils through the esophagus into the stomach to drain the stomach and drain the GIT. What is the value of this nasogastric suction? The value of this nasogastric suction A preoperative value is that it relieves the pain and the distension because it will aspirate the fluid in the proximal dilated intestine, so the dilated intestine will relapse or recoil and regain its normal size. Okay, the cause of pain is overstretch or stretch of the smooth muscles in the wall of the intestine. So if we drain this fluid, the smooth muscle will regain its normal size and there will be no hyperperistalsis. So but first, it will relieve pain and distension. Second, it will help with the return of the bowel movement. Okay? Okay. What is the operative value of nasogastric suction? It prevents vomiting under anesthesia and inhalational pneumonia. And second, it removes the toxins. These toxins may be absorbed after release of the obstruction and cause septicemia. The third, gut decompression facilitate handling and abdominal closure. Okay, the post-operative value is that it decreases the risk of post-operative ileus. So, any baby present by neonatal intestinal obstruction, we have to put a nasogastric tube because this nasogastric tube has many values: pre-operative, operative, and post-operative. The second, we have to correct the fluid and the electrolyte disturbances that may be present in the baby. First, we have to give a bolus dose of Ringer solution in a dose of 20 milliliters per kg. And it can be repeated according to the degree of dehydration. After giving the shock therapy, we will maintain the fluid intravascular volume by maintenance dose of intra-IV fluid after correcting dehydration in a dose of 150 milliliter per kg per day in units. Okay, in addition to correction of fluid disturbances, we have to correct the electrolytes and ABG. Okay, arterial blood gas disturbances and the electrolyte should be corrected. Okay, in addition, to guard against infection, we have to give a broad spectrum antibiotics and intravenous metronidazole or flagyl to guard against infection. Fourth, we have to do rapid screening to detect associated merger anomalies. As we said, any baby presented by the picture of congenital anomaly like neonatal intestinal obstruction, we have to search for other anomalies, and the most common is the bacterial association. Okay, this baby is going to do an operation, so we have to prepare blood. So preparation of a cross-matched bag, the RBCs or fresh blood, and the blood is transfused in a rate of 20 milliliter per kg. Okay, after preparing the baby, we will go to the OR. We will go to the OR and do a laparotomy. Laparotomy means we will open the abdomen to explore and find the level of obstruction, the cause of obstruction, and deal with that. So we do an exploration to identify the level of obstruction, meaning that the obstruction is at the level of the duodenum, the jejunum, the ileum, or the colon, and the cause of obstruction, meaning that what is the cause of obstruction? It may be atresia, it may be stenosis, it may be a meconium ileus, it may be a malrotation, it may be a band or something like that. So the value of exploration is we identify the level of obstruction and we will detect the cause of obstruction. After that, we have to manage the cause of obstruction to relieve this condition. Okay, so this is an overview of neonatal intestinal obstruction. First, we define what is the neonatal intestinal obstruction. The second, we enumerate the causes of neonatal intestinal obstruction, and we explained what is the pathophysiology of intestinal obstruction as a whole. After that, we mentioned the clinical presentation of neonatal intestinal obstruction and what are the investigations that we need in case of neonatal intestinal obstruction. After that, we prepared the baby for the operative treatment by pre-operative preparation and then operative management. After that, we will explain the most common causes of neonatal intestinal obstruction and we will apply what we have just studied in this condition. We will take 4 or 5 conditions rapidly. The first is duodenal obstruction. Duodenal obstruction means neonatal intestinal obstruction at the level of the duodenum. First, what are the causes of duodenal obstruction? Duodenal obstruction may be from inside the duodenum or maybe from outside the duodenum. From inside the duodenum is the atresia or web, as we explained before. Atresia means loss of continuity of the intestine. Okay, web means membrane or diaphragm obstructing the wall of the intestine. So the intrinsic obstruction means duodenal atresia or a web. Okay, extrinsic obstruction means something that is producing compression of the duodenum, like annular pancreas, periduodenal portal vein, or intestinal malrotation. Annular pancreas. What is the meaning of annular pancreas? Normally, the pancreas is present in the medial aspect of the concavity of the duodenum only. There is no pancreatic tissue on the lateral aspect of the duodenum. Sometimes during development of the pancreas develops from a ventral and dorsal bud. This ventral and dorsal buds should fuse on the medial aspect of the duodenum. Sometimes failure of rotation results in the presence of pancreatic tissue on the lateral aspect. So the pancreas encircles the second part of the duodenum, producing what we call annular pancreas. Periduodenal portal vein. Normally the portal vein passes behind the duodenum. Sometimes the portal vein, as a congenital anomaly, the portal vein passes in front of the duodenum, produces periduodenal portal vein. And intestinal malrotation, as we will discuss later, produces duodenal obstruction by the Ladd's bands. These are a congenital bands that cross from the cecum that is present in abnormal location in the middle of the abdomen and crosses over the duodenum to the lateral abdominal wall. These bands can compress the duodenum and produce extrinsic obstruction. So extrinsic duodenal obstruction is the annular pancreas, periduodenal portal vein, and intestinal malrotation. Okay, a baby with neonatal duodenal obstruction will be presented by the same picture as we said: maternal polyhydramnios, early vomiting. The abdominal distension will be mild or just epigastric, and it will not be so marked. And the meconium, the baby may pass meconium for 1 or twice. Okay, the meconium usually passes in the first 24 hours, followed by constipation. So the clinical picture of duodenal obstruction is the same as we said: maternal polyhydramnios, bilious vomiting, abdominal distension is not marked, and the baby usually fails to pass meconium, or if he passes the meconium just for once or twice and then will be constipated. Okay, this is the clinical picture. After that, we will do a plain X-ray. As we said, in the plain X-ray, in duodenal atresia, you will find a gas in the stomach and the gas in the abdomen, and the rest of the abdomen will be gasless. So this is called double bubble sign. So the double bubble sign occurs in the duodenal obstruction. So if we did a plain X-ray, you will find a double bubble sign and there is no gas in the distal duodenum. This is if there is complete obstruction. If there is partial obstruction, you will find paucity of gas. There will be a few gas distal in the distal part of the intestine. Okay, if we did ultrasound, it can also detect the presence of the double bubble sign. It can see the gas in the stomach, the gas in the duodenum, and the rest of the abdomen is gasless. So the investigation needed in case of duodenal obstruction: plain X-ray, we will detect the double bubble sign, and we can do an ultrasound examination. Okay, what is the treatment of duodenal obstruction? The treatment of duodenal obstruction, as we said, we have to do a laparotomy. We have to open the abdomen and detect the level of obstruction that is in the duodenum, and then we will detect the cause of obstruction. The cause of obstruction may be, as we said, atresia, maybe annular pancreas, maybe malrotation, maybe periduodenal portal vein. Okay, the surgical treatment in case of duodenal obstruction is to anastomose the duodenum before the level of obstruction to the level beyond the obstruction. So we bypass the level of obstruction. This is done by anastomosing the duodenum before to the duodenum after the obstruction, what we call duodenostomy. So we suture the duodenum before to the duodenum after. But the surgical treatment of choice in duodenal obstruction is the duodenostomy. Okay. If there is a duodenal web, means that there is a membrane or a diaphragm occluding the lumen of the duodenum, we can do excision of the web. We open the duodenum longitudinally and excite the web, and then the duodenotomy is closed transversely. But if we did this, if we excite the web, we have to be careful, because the most common site of the web is just adjacent to the ampulla of water, and so during excision of the web, you have to be very careful not to injure the ampulla of water. Okay, so this is the duodenal obstruction. The second condition is intestinal malrotation. Okay, intestinal malrotation, as we said, there is during intrauterine life, the midgut develops from the two loops of the intestine, that is the cecocolic limb and the duodenojejunal limb. The duodenojejunal limb is the cranial one that is toward the head of the baby, and the sucocolic limb is the one caudal, means toward the lower part of the baby. The process of rotation of the intestine, as we said, passes into 3 stages. First 90 degree to the counterclockwise, and then 180 degrees counterclockwise. The result of mid-gut rotation, the last result is that you will find the normal orientation of the small intestine as the duodenum will have a C shape with the pancreas in its concavity. The duodenal junction will be to the left of the vertebral column, and the cecum will be in the right iliac fossa. The small intestine will be in the middle of the abdomen, and the colon will be in the periphery of the abdomen. Failure of this process, failure of this orientation, will result in intestinal malrotation, means that the intestine will not be oriented into the normal position. So the duodenum will not take its C shape. The duodenal junction will not be to the left of the vertebral column, to the left side of the vertebral column. The small intestine will not be in the middle of the abdomen, and the colon will not be in the periphery. What occurs in intestinal malrotation is that the duodenum will be straight, coming from the right side of the abdomen. It will not be C-shaped. No, it will be straight. The small intestine will be on the right side of the abdomen. The cecum will be in the mid part of the abdomen, okay, and it is very close to the duodenum, and it is attached to the duodenum by bands called Latz bands, and the colon will be to the left side of the abdomen. So in intestinal malrotation, the normal orientation of the intestine is not evident, but you will find the duodenum and small intestine on the right side of the abdomen, the cecum in the middle of the abdomen, the colon on the left side of the abdomen. The cecum becomes attached to the duodenum by bands called Latz bands. These Latz bands may be the cause of obstruction of the duodenum that occurs in cases of duodenal obstruction. Okay. Normal gut rotation. The result of normal gut rotation is that you have a broad-based mesentery. The broad-based mesentery means that the base of the mesentery is the extent of the root of the mesentery from the duodenal junction to the left of the vertebral column to the cecum in the right iliac fossa. Okay. The duodenum is fixed securely to the retroperitoneum as a C loop. This is the result of normal gut rotation. Okay, if fixation does not take place, as that occur in intestinal malrotation, the intestine is suspended by a thin stalk containing the superior mesenteric vessel and is susceptible to mid-gut volvulus, means that there may occur a twist of the mid-gut around its arterial supply, that is the superior mesenteric artery, and if this twist is complete, meaning that it includes 270 degrees at least, it will result in mid-gut volvulus and ischemia of the mid-gut. Okay. A baby with intestinal malrotation will be presented by a picture similar to that of duodenal obstruction if it is simple. Simple means there is obstruction but without volvulus. Okay, so 90% of symptomatic patients presented during infancy, most of these in the newborn period. Okay, the newborn with malrotation is at a great risk of life-threatening mid-gut volvulus, although it can occur at any age, meaning that the volvulus can occur in the newborn and can occur later on, but the risk of volvulus is much greater in the newborn period. And the most common presentation of meconium ileus at that of duodenal obstruction is the bilious vomiting and less marked abdominal distension. Marked abdominal distension indicates the occurrence of volvulus. So in intestinal malrotation, it can be presented by a picture similar to the duodenal obstruction, that is the bilious vomiting and less abdominal distension or epigastric distension. Okay, if there is marked abdominal distension, the marked abdominal distension indicates that the midgut go into a volvulus and much of the lobes become dilated. Okay, the most common presentation is bilious vomiting. This is due to the duodenal obstruction from intermittent midgut volvulus rather than compression by the Latz bands or kinking of the duodenum. to diagnose a baby with intestinal malrotation, based on the clinical, it is only the picture that is similar to duodenal obstruction, so we cannot differentiate it between duodenal obstruction and malrotation. But to diagnose it properly, we have to do a radiologic study. In the plain abdominal radiographs, we will demonstrate obstruction and abdominal distension. Like any case of obstruction, you will find dilated duodenum or dilated small intestinal lobes. The gasless abdomen will be detected when the volvulus has created a closed lobe obstruction. So gasless abdomen in a case of suspected malrotation indicates that volvulus had occurred. Okay, so the plain abdominal radiographs will demonstrate obstruction, means dilated loops, and abdominal distension. The second, the gasless abdomen, if there is gasless abdomen, this indicates the occurrence of the volvulus. The definitive diagnosis of intestinal malrotation is by contrast radiographic studies. Okay, so if we do a contrast study, and as we said, the contrast study, we give a contrast like a gastrographin or tibarium, either from above in gastrographin swallow meal and follow through, or from below, that's gastrographin enema. Okay, in gastrographin in upper GIT series, like the gastrographin meal follow through, we will demonstrate the site of obstruction and the presence of malrotation. In the presence of malrotation, we will find that there is loss of the C shape of the duodenum, meaning that the duodenum will be straight. The duodenum will be moving from to the right side of the vertebral column. It will not take its normal C shape. If there is volvulus, there will be an abrupt cut off to the passage of the barium that is called Bird's Peak in the third part of the duodenum, and the duodenal obstruction may be only partial and have a spiral or corkscrew appearance. Partial obstruction of the duodenum may present a corkscrew appearance. We can also do a barium enema to define the position of the cecum. As we said, the cecum in cases of intestinal malrotation is present in the mid of the abdomen and not in the right iliac fossa. Normally, the cecum should be present in the right iliac fossa, while in cases of intestinal malrotation, the cecum is present in the mid-abdomen. So, if we did a barium enema study, this barium enema will identify the position of the cecum. In the case of malrotation, we will find the cecum in the mid of the abdomen and not in the right iliac fossa. Okay? Okay. We can do an ultrasonography. The ultrasonography with Doppler study to identify the position of the superior mesenteric vessel. Normally, we have a superior mesenteric artery and superior mesenteric vein, and there is a constant relationship between the artery and the vein, meaning that the vein is to the right of the artery. So normally, the superior mesenteric vein is to the right side of the superior mesenteric artery. Okay, and in intestinal malrotation, because of rotation of the intestine around its axis, so there will be a reversed relation between the superior mesenteric artery and the vein. The absence of the normal relation between the superior mesenteric artery and the vein in Doppler ultrasonographic study strongly suggested the presence of malrotation. So we diagnose malrotation clinically as the baby will be presented by a picture similar to that of duodenal obstruction, like that, bilious vomiting and moderate abdominal distension or mild abdominal distension or epigastric distension. Okay, if the baby has much abdominal distension and the abdomen is tender, this indicates that the volvulus has occurred. Okay, if we suspect malrotation, we will do a plain X-ray and we will do a dye study. The dye study from above, gastrographin meal and follow through, we will detect that in the abnormal position of the duodenum lost its C shape, the stomach will be on the right side of the abdomen, the colon will be to the left side of the abdomen, and the cecum will be in the mid-abdomen. To detect the position of the cecum, we will do a barium enema study. The barium enema study will detect the position of the cecum. And to show the relation between the superior mesenteric artery and the vein, we will do a Doppler ultrasonography. If we find that the relation is abnormal, this indicates the presence of intestinal malrotation. Okay, what is the treatment of senile malrotation? The treatment of senile malrotation is to do a laparotomy. We will open the abdomen and we will detect the obstruction. Okay, after we get into the abdomen and they detect that there is a senile malrotation, the operation done is called lead operation or lead procedure, and this includes 6 steps. The first step is evisceration, meaning that we will take the loops outside of the abdomen to explore it, and then we will do untwisting of the volvulus, meaning that we will detort the intestine. The intestine is rotated around its mesentery. We will do detortion of the intestine. So we will do untwisting of the volvulus. After that, we will do division of the Ladd's bands. And as was said, Ladd's bands are congenital bands that pass from the cecum to the lateral abdominal wall, crossing over the duodenum. These bands may obstruct the duodenum, and so we have to divide these Ladd's bands. Okay, after that we will do widening of the mesenteric base. As was said, the base of the mesentery is the part between the duodenojejunal junction to the cecum. In case of malrotation, because the cecum is close to the duodenum, so the base of the mesentery is very narrow. This narrow base of mesentery makes the intestine liable to rotation, and this rotation will result in volvulus. Okay, to prevent this rotation and volvulus, we will do widening of the base of the mesentery. After that, we will do a relief of duodenal obstruction by doing mobilization of the duodenum. Mobilization of the duodenum from the posterior abdominal wall is called cochorization of the duodenum. And the last steps is called incidental appendectomy. After we correct malrotation and we do normal orientation of the intestine, and we will orient the intestine. In malrotation, the orientation of the intestine is that the small intestine will be on the right side of the abdomen, and the cecum and the colon will be on the left side of the abdomen. So in a baby with malrotation, after operation, the appendix will be in the left iliac fossa. So in the future, when this baby gets an attack of acute appendicitis, the pain will be experienced by the baby in the right iliac fossa, although the appendix is in the left iliac fossa, because the pain is connected, or the pain is related to the nerve supply and not to the location. Okay, so the nerve supply of the duodenum will reflect the pain to the right iliac fossa, although the appendix is in the left iliac fossa. To prevent mishaps in this condition, so in the past they did incidental appendectomy, meaning that they remove the appendix to prevent future mishaps. Okay, nowadays we don't do appendectomy, but we report to the parent that the appendix is in the left side of the abdomen. If this baby gets an attack of acute appendicitis, so the surgeon will go to the left side, not to the right side, etc. So this is the treatment of malrotation by a procedure called lead procedure. Okay. After that, we will get the jejunal atresia, meaning that atresia involving the jejunum or the ileum. As we said, atresia means atretic segment, means loss of continuity of the intestine due to intravascular accident that results in ischemia of a part of the bowel. Okay, there are many types of intestinal atresia: type 1, type 2, type 3, and type 3 is divided into type 3A and type 3B, and type 4. Okay, these are just a classification of the different types. You are not obliged to know what are the types, but just to enumerate. Okay. Jejunal atresia can be diagnosed as any case of intestinal obstruction. This baby usually presents within the first 1 or 2 days with bilious vomiting, abdominal distension, and failure to pass meconium. Okay, so this baby will be presented by bilious vomiting, abdominal distension, and failure to pass meconium. If we did a plain X-ray, the plain X-ray will show dilated bowel loops with air and fluid levels. Okay, the barium enema will demonstrate a small and unused colon, and often the dye will reflux the contrast into a collapsed terminal ileum. The treatment of jejunal atresia is to do a laparotomy, to open the abdomen and start exploration to define the level of obstruction and the cause of obstruction. Okay, in atresia, the proximal intestine will be the part of the bulbous part of the dilated intestine will be resected, and the distal bowel will be opened and irrigated to rule out the distal atresia or distal obstruction. Okay, the dilated bulbous part is resected or tapered, and the intestinal continuity is re-established by primary anastomosis, meaning is to anastomose the proximal dilated intestine to the distal collapsed intestine. Okay. The fourth condition is the meconium ileus. As we said in the introduction, meconium ileus is a systemic disease, or meconium ileus, we call it the intestinal manifestation of a systemic disease called cystic fibrosis. The cystic fibrosis results from a mutation of the cystic fibrosis gene that is located on the long arm of chromosome number 7. 90% of children with cystic fibrosis will have pancreatic enzyme deficiency and or abnormal meconium composition. So, this baby have deficient pancreatic enzymes. The deficient pancreatic enzyme will result in failure of digestion of the protein content in the meconium. So this meconium will have a high protein content. The high protein content in the meconium will make this meconium very thick, very viscid, and tenacious, and so it will become adherent to the wall of the intestine in the narrowest part of the intestine. What is the narrowest part of the intestine? The narrowest part of the intestine is the distal ileum. So the meconium ileus is a baby that is presented by the picture of distal ileal obstruction, okay, due to meconium that is adherent to the wall of the terminal ileum. However, the meconium abnormality is sufficiently severe in 10 to 20% of the affected neonates to produce tenacious, thick meconium that adheres to the distal ileal mucosa, producing distal intestinal obstruction. These babies are presented by the picture of neonatal intestinal obstruction, that is bilious vomiting, abdominal distension, failure to pass meconium. So there is a generalized abdominal distension because the obstruction here is a distal obstruction, and as we said, in distal obstruction you will find marked abdominal distension. So there will be a generalized abdominal distension developing within the first 24 to 48 hours, okay, and then there will be bilious vomiting and failure to pass meconium within the first 1 or 2 days. Okay, this is called simple meconium ileus. So in simple meconium ileus, the baby will be presented by bilious vomiting, marked abdominal distension, and the failure to pass meconium. Okay, if it is complicated meconium ileus, the complicated meconium ileus results from volvulus in the proximal dilated bowel, meaning that the proximal dilated bowel will rotate around its mesentery and produce a volvulus. So, complicated meconium ileus results from volvulus in the proximal dilated bowel and present shortly after birth with severe abdominal distension, bilious vomiting, respiratory distress, hypovolemia, and hemodynamic instability. Okay? If we suspect meconium ileus, we will do a plain X-ray. The plain X-ray, it will show, as in a case of intestinal obstruction, it will demonstrate a dilated loops, okay? But peculiar to the meconium ileus that there will be dilated loops and there will be no air fluid levels. So in meconium ileus, we will find dilated loops and we will find no air fluid level even in the erect film. So, the abdominal radiographs will demonstrate dilated loops with relative absence of air fluid levels, and there will be a ground glass or soap bubble appearance in the right lower quadrant, where the bowel loops are filled with thick meconium that is mixed with air. Okay, if we did a contrast enema, so there will be a small unused colon and there will be meconium pellets in the terminal ileum. This is the viscid thick meconium, like a pellet. Okay, the water-soluble contrast enema will show a small and unused microcolon and inspissated meconium pellets in the distal ileum. Because meconium ileus is a part of the condition called cystic fibrosis, the cystic fibrosis is diagnosed by one of the methods of diagnosis of cystic fibrosis is the sweet chloride test. So if we suspect that meconium ileus is a part of cystic fibrosis, we have to do the sweet chloride test. Okay, how to treat a case of meconium ileus? As we said, simple meconium ileus can be managed non-operatively because the problem in meconium ileus is that the meconium is viscid and thick, and so it becomes adherent to the wall. But there is no atresia, there is no stenosis. So if this meconium becomes soft, it can pass down into the colon and the obstruction can be relieved. So the simple meconium ileus can be managed non-operatively with gastrographene enema. The gastrographene is a hygroscopic material. The gastrographene, this is some sort of dye that is used in radiologic suits. This gastrographene, it is iodine-based material, and it is hygroscopic. Hygroscopic means that when it is instilled into the GIT, it will shift the fluid from the intravascular volume to the inside of the intestine. Okay, when the fluid becomes mixed with the meconium, it will make the meconium more soft, and this meconium can leave the wall of the intestine and pass down into the colon, and the condition can be relieved. So simple meconium ileus can be managed non-operatively with gastrographene enema or N-acetylcysteine. Both of them are the gastrographene acts by its hygroscopic action, and N-acetylcysteine acts by its mucolytic effect. Okay, oral N-acetylcysteine can also be given to help clear the thick meconium, which usually begins to pass within 12 to 18 hours following enema. Okay, so the primary management of simple meconium ileus is non-operatively. We can give either a gastrographene enema or N-acetylcysteine. Okay, when we need surgical intervention. Surgical intervention is required in first, most neonates with complicated meconium ileus. If meconium ileus becomes complicated by volvula, there is no place for conservative treatment or non-operative treatment. The second, if the neonate with simple meconium ileus and they have 2 or 3 unsuccessful trials of gastrographene enema, if we did trials of gastrographene enema or N-acetylcysteine for 2 or 3 times and these trials are not successful, so we will shift to the surgical treatment. The surgical treatment is to do a laparotomy. We explore the abdomen and we will get the intestine out, and we will detect the level and the cause of obstruction. Then we will do an enterotomy. We will do an opening in the wall of the intestine. After that, and we will do irrigation with normal saline or warm saline to get this meconium out. After that, we have many options. Either we will close the enterotomy, and the baby will be keep fasting for 3 or 4 days after that, and then start oral feeding. Or sometimes we can do stoma. Stoma means is to extruorize the intestine on the outside. Extruorization of the intestine can be done by many techniques. One of them is Bishop Cope or Macolex or Santulli plank. Okay. In laparotomy, when we explore the abdomen, we will find that the distal ileum is collapsed and the proximal is dilated. We will do enterotomy. We will do an opening in the intestine and then do washing to get this meconium out. And then after that, we can close the enterotomy and do a primer anastomose, or sometimes we can do one of these stomas. Okay, stomas, either Henneck-Macolex stoma, Bishop Cope or Santulli plank stoma. Okay. The last condition is the Hirschsprung disease. Hirschsprung disease is called functional obstruction. Functional obstruction means that the lumen is patent. The lumen of the intestine is patent, but there is a problem with the peristaltic movement of the intestine. So Hirschsprung disease is a type of distal obstruction, because Hirschsprung disease affects the rectum with a variable degree of the colon. So Hirschsprung disease is a type of distal obstruction, and as we said, the distal obstruction is usually presented later by a picture of marked abdominal distension, early constipation or failure to pass meconium, and delayed vomiting. Okay. In Hirschsprung disease, it is a developmental anomaly caused by migratory failure of neural crest cells. As we know, the peristaltic movement of the intestine is controlled by the local nerve supply of the intestine that is called enteric nervous system. Okay, the source of this enteric nervous system is from the neural crest cells. The neural crest cells, the ganglion cells migrate from the neural crest and reside in the wall of the intestine and produce two plexuses, okay, the myenteric plexus, okay, and the Orpich plexus. These two plexuses control the motility of the intestine. Okay, The intestine has its intrinsic nerve supply, that is the enteric nervous system, but also has extrinsic nervous system. The extrinsic nervous system is the sympathetic and the parasympathetic nerve supply. The sympathetic and the parasympathetic nerve supply are not necessary for initiation of the movement, but the value of extrinsic nerve supply, that is sympathetic and parasympathetic, is to regulate the intestine. Regulate the motility of the intestine. So the initiation of the movement is from the intestine itself through the enteric nervous system, but the extrinsic nerves can either increase or decrease this movement. So the extrinsic nerve supply only control it, either increase or decrease. So in Hirschsprung disease, it is a developmental anomaly caused by migratory failure of the neural crest cells. When these primitive neurogenic cells fail to take position in the submucosal and intermesenteric plexus of the bowel from the lip to the anus, motility disturbance result that most routinely present as chronic constipation in a newborn child, that is called Hirschsprung disease. So in Hirschsprung disease, there is failure of innervation or eganglionosis of a segment of the bowel. The segment of the bowel usually starts from the rectum and may go up. Okay, it may take only the rectum, or may take the rectum and the part of the sigmoid, or may take the rectum, sigmoid, and the part of the descending, etc., giving different levels of the disease. So Hirschsprung disease means dilatation and hypertrophy of the colon as a result of distal obstruction that results from failure of the ganglion cells as the result of failure of the ganglion cells to innervate the distal rectum and colon. In Hirschsprung disease, we will find, as in this picture, you will find, if you look to the left side picture, you will find that the colon has the same caliber all through. The rectum somewhat dilated. This is called the ampulla of the rectum for its reservoir function, but the most of the colon have the same caliber. If you look at the right side picture, you will find that the colon is dilated and there is a spastic and collapsed distal segment. The collapsed distal segment, this is the ganglionic segment, and the dilated segment, this is the ganglionic segment. So in Hirschsprung disease, we have three zones. Okay, we have three zones. Okay, the ganglionic segment, that is the collapsed and the empty, and it is spastic. The transition zone, this is a funnel shape where the ganglion cells are present, but it is few. We call it hypoganglionic segment. And the dilated colon, that is the ganglionic segment. So we have a ganglionic zone, hypoganglionic zone, and the ganglionic zone. The hypoganglionic zone, the transition zone between the ganglionic and the ganglionic segment. These babies are usually presented clinically by failure to pass meconium within the first 1 or 2 days, and in Hirschsprung disease, 90% of babies fail to pass this meconium. The disease progresses to abdominal distension, bilious vomiting, and possibly obstructive enterocolitis. Enterocolitis means inflammation of the intestine as a result of partial obstruction that leads to stagnation of the intestinal secretion and secondary bacterial action. If a neonate leaves the hospital without diagnosis, he will reappear with the picture of chronic constipation within the first 2 years of his life. The constipation often accompanies the dietary changes from the breast milk to the formula, or from the formula to the solid food. Rarely the children escape diagnosis until more advanced age, when chronic constipation and failure to thrive are seen. So, the clinical presentation of Hirschsprung disease may be the picture of neonatal intestinal obstruction, that is failure to pass meconium, abdominal distension, and bilious vomiting, or sometimes the baby pass this early presentation and may be presented late by the picture of chronic constipation, and if the condition becomes progressive, this baby may be presented by the manifestation of failure to thrive. To diagnose Hirschsprung disease based on the clinical presentation, we have to do a perium enema. As we said, we have three zones. That is the ganglionic segment and hypoganglionic segment and the ganglionic segment. So you will find three zones. That is the spastic colon, the spastic and collapsed colon, and then the funnel, and then the dilated colon. So the barium enema reveals a spastic, poorly compliant rectum with eventual passage through a cone-shaped transition zone. This is the hypoganglionic zone, and then the dilated colon, that is the normally ganglionic colon. So we have three zones. Okay, the dilated colon, that is the normal ganglionic colon, and then the transition zone. The transition zone, this is the funnel part. This is the intermediate zone between the dilated and collapsed segment. This zone usually has a few ganglion cells. We call it hypoganglionic. And the distal collapsed and the spastic segment, this is the aganglionic segment. Okay, delayed films reveal slow clearance of the contrast and may reveal the transition zone better. Okay, the second to diagnose Hirschsprung disease is to do rectal punch biopsy. As we said, the cause of Hirschsprung disease is aganglionosis of a segment of the bowel, means that loss of the ganglion cells either in the submucosal plexus or in the myenteric plexus or the Orpich plexus. So if we take a biopsy from the wall of the colon and send it to a pathologist to look for the ganglion cells, there will be absence of the ganglion cells. Okay, to diagnose Hirschsprung disease, we will take a rectal biopsy. The rectal biopsy is usually taken 2 centimeters above the dentate line. The biopsy will demonstrate absence of the ganglion cells and compensatory hypertrophy of the nerve bundle. So there will be a ganglionosis and associated hypertrophy of the nerve bundles. Special stains can further delineate acetylcholinesterase activity in the abnormal quantities or a variety of neuronal markers. Okay. The third test to diagnose Hirschsprung disease is the anorectal manometry. Anorectal manometry, normally innervated colon, distension of the rectum produces reflex relaxation of the internal sphincter, which is easily assessed with the diagnostic manometry, and this is called rectoanal inhibitory reflex. Rectoanal inhibitory reflex means that distension of the rectum will produce relaxation of the internal sphincter. So the rectoanal inhibitory reflex is dependent on the local nerve supply in the wall of the rectum. In Hirschsprung disease, there is deficiency of the nerve supply in the wall of the rectum, so this reflex will be absent. Okay, in normal innervated colon, distension of the rectum produces reflex relaxation of the internal sphincter, which is easily assessed with the diagnostic manometry. Failure to demonstrate this normal reflex strongly suggests Hirschsprung disease. So, the diagnosis of Hirschsprung disease depends first on the clinical presentation, as was said, either neonatal presentation by the picture of neonatal intestinal obstruction or later presentation by the picture of chronic constipation and the failure to thrive. After that, we can confirm the diagnosis by barium enema, rectal punch biopsy, and the anorectal manometry. After diagnosing the Hirschsprung disease, we have to treat this condition. The treatment of this condition relies on, we have to resect the aganglionic segment and the transition zone, and then bring the ganglionic bowel to the anal canal and anastomose the well-ganglionated bowel to the anal canal. Okay, so the treatment of Hirschsprung disease depends on resection of the aganglionic segment and colonic pull-through procedure of the different variations are the current definitive therapy. There are many operations with the same principle, so whatever the type of the operation, it has the same principle. We have to resect the aganglionic segment and the transition zone and bring a well-ganglionated bowel to be anastomosed to the end of the rectum and the upper anal canal. So, resection of the aganglionic segment and the colonic pull-down procedure of different variation are the current definitive therapy. Okay, there are many techniques that can be done to treat Hirschsprung disease, like Swenson operation, Sauvé operation, Duhamel operation, transanal endolectal pull-through, okay, and laparotomy or laparoscopy assisted pull-through if the transition zone is very high or the aganglionic segment is very long. For example, if the transition zone is in the descending colon or in the transverse colon. So, to do the Hirschsprung disease, we have to open the abdomen to resect the whole of the aganglionic segment and mobilize the colon and bring it down. This can be done either by laparotomy, by opening the abdomen, or by laparoscopy through the use of a laparoscope. Okay, so the operation done for his brain disease includes Swenson operation, Soave operation, Duhamel operation, transanal endorectal pull-through, either laparotomy or laparoscopy assisted pull-through. Okay, thank you.